Good afternoon, and thank you for inviting me at the 10th Annual SIU Conference. I'm Katia Boleti, medical oncologist at the Royal Free Hospital in London, and I would like to talk to you today about current trends in immunotherapy for metastatic renal cell carcinoma. During my talk today, I will present to you a few background points. I will continue with the current immunotherapy treatment options for metastatic renal cell carcinoma with a focus on first-line therapies. I will continue with the new first-line combinations, and then I will proceed with future directions before I complete my talk with the conclusions. Advanced renal cell carcinoma comprises 3 to 4% of all adult malignancies and 90% of all kidney cancers. Incidence rates are predicted to rise to approximately 32 cases per 100,000 people by 2035. Clear cell is the commonest type, with approximately 75% of all cases, followed by papillary type 1 and 2, chromophobe, collecting duct, medullary, and oncocytoma. The incidence of new cases between 2014 and 2016 on average were approximately 13,000 new cases, with a mortality of 4,600 deaths in 2016. 25 to 30% of patients present with metastatic disease, and the commonest sites of metastasis are lungs, soft tissue, bones, and liver. The 5-year survival rate for patients diagnosed with advanced disease is rather poor. There is no doubt that immune checkpoint inhibitors are not only here to stay, but are now an essential part of the treatment tools that we have for patients with advanced and metastatic renal cell carcinoma, alongside the tyrosine kinase inhibitors, which are well established. The treatment landscape is now evolving fast and includes ever-improving combinations of immune checkpoint inhibitors with or without other agents. There is a variety of phase 3 trials which are being published in order to address the management options in the first-line setting. Just to give you an idea and put you in the picture of the impressive changes that have taken place over the past 20 years, have a look on the left-hand side, and the graph demonstrates the survival of patients in the year 2000, the cytokine era, with a median overall survival of 10 months, while the favorable risk patients at the time had a median overall survival of 27 months, and the poor risk patients a survival of about 6 months. Fast forward in the year 2009, when the targeted therapies are established, and the median overall survival has significantly improved to 22 months, with the poor risk patients still, however, having a poor survival rate, requiring further improvement. The European Society for Medical Oncology guidelines for advanced clear cell carcinoma reflect the new advances that we have experienced over the past few years, and as you can see in the column of the standard options for all 3 risk groups includes combinations of immunotherapy with another agent, while the tyrosine kinase inhibitors have now been relegated in the alternative options. And moving to the current immunotherapy treatment landscape for metastatic renal cell carcinoma, I would like to mention the emerging significant role of the tumor microenvironment, whose immune component is involved in complex interactions, including both pro and anti-tumor effects, and whose immune checkpoints are involved in signal transduction pathways resulting in T-cell energies, while others disrupt cytokine production and antigen-presenting cell maturation, which can result in immunosuppression. Furthermore, costimulatory immune checkpoints can be used to stimulate immune responses. Beyond the direct immune effects, metabolic changes can influence the tumor microenvironment, providing immunosuppressive metabolites and favoring tumor growth in hypoxic conditions. Furthermore, the tumor microenvironment can acquire immunosuppressive features by reprogramming metabolic processes. Also, angiogenesis, which is well known to be essential for the progression of renal cell carcinoma, can be related to the recruitment of tumor supporting endothelial cells, which are different than the normal endothelial cells. Also, known anti-angiogenic agents can change the tumor microenvironment by recruiting immune effector cells that could promote anti-tumor immune responses. The pivotal study was the Phase 3 Checkmate 214 study, a randomized open-label study comparing nivolumab and ipilimumab with sunitinib in 1,096 patients who were treatment naive with advanced or metastatic renal cell carcinoma. The patients were randomized on a 1-to-1 randomization to nivolumab and ipilimumab or sunitinib, with the randomization being stratified for the IMDC prognostic score and geographic region. Patients in the sunitinib group were treated in a 6-weekly cycle consisting of 4 weeks on treatment and 2 weeks off treatment. The treatment continued until disease progression or unacceptable toxicity. The co-primary endpoints were objective response rate, progression-free survival, and overall survival in intermediate and poor risk patients, with secondary endpoints being objective response rate, progression-free survival, overall survival, and safety in the intent to treat population. The results were published in 2018 in the New England Journal of Medicine. At 42 months follow-up, there is clear evidence that for the intermediate and poor risk patients, there is sustained benefit by using the combination of nivolumab and ipilimumab with a hazard ratio of 0.66, which is not replicated in the intention to treat patients who have a hazard ratio of 0.89, but this is not statistically significant. With regards to the durability of response at 42 months in the intent to treat population, the median time to response in complete responders was 2.8 months. The median duration of response in complete responders has not been reached yet, while 86% of complete responders had ongoing response at 42 months. The second combination to be approved is that of pembrolizumab and axitinib, although unfortunately this is not available in the UK, where it was not recommended by NICE. It got its European approval in September 2019. Pembrolizumab is an anti-PD-1 antibody, while axitinib is a well-established tyrosine kinase inhibitor with specific action against VEGFR1, 2, and 3. It is used as a combination with pembrolizumab given as 200 mg intravenously every 3 weeks for a maximum of 35 cycles, and axitinib 5 mg BD until disease progression or unacceptable toxicity. The regulatory approval of pembrolizumab and axitinib was based on the publication of the Phase 3 pivotal study Keynote 426, which was a Phase 3 randomized open-label study evaluating the efficacy and safety of pembrolizumab in combination with axitinib versus sunitinib monotherapy, which was the standard of care as first-line treatment option. The patients who were included in the study were newly diagnosed or recurrent stage 4 clear cell carcinoma patients with no previous systemic therapy for advanced disease, good performance status, and presence of at least one measurable lesion. Stratification factors included the IMDC risk criteria, while the endpoints included as co-primary endpoints progression-free survival and overall survival, and secondary endpoints the objective response rate, duration of response, and safety. Median survival was not reached in either group. The risk of death was 47% lower in the pembrolizumab axitinib group compared to the sunitinib group, with a hazard ratio of 0.53. In the pembrolizumab and axitinib group, 5.8% of patients were complete responders, with partial response demonstrated at 53.5% and stable disease at 24.5%. In the sunitinib group, the complete responders were 1.9%, with partial response shown in 33.8% and stable disease at 39.4%. In summary, and with regards to the KEYNOTE-426 trial and the pembrolizumab axitinib combination, the median progression-free survival was significantly longer in the pembrolizumab axitinib group compared to the sunitinib group. The risk of death was 47% lower in the pembrolizumab axitinib group compared to the sunitinib group, and the median survival was not reached in either group. Significantly more patients in the pembrolizumab axitinib group achieved a confirmed objective response compared to the sunitinib group, while grade 3 or more treatment-related adverse events occurred in 62.9% and 58.1% of patients in the combination arm versus the sunitinib group, respectively. The next immunotherapy TKI combination is that of avelumab and axitinib. Avelumab is an anti-PD-L1 antibody, and axitinib, again, the TKI directed against VEGFR1, 2, and 3. The pivotal study was the Javelin Renal 101 study, and it got its EU approval in October 2019, with a NICE approval being granted in September 2020. The patients who took part in this multicenter randomized open-label phase 3 trial were treatment naive with advanced or metastatic renal cell carcinoma with a clear cell component, had good performance status and at least one measurable lesion, and were stratified according to their PD-L1 status. The randomization was 1:1, and half of the patients received avelumab axitinib, avelumab being given every 2 weeks as an intravenous infusion, and axitinib as tablets 5 milligrams BD, versus the standard sunitinib combination of 50 milligrams once a day, 4 weeks on, 2 weeks off. The co-primary endpoints were progression-free survival and overall survival in the PD-L1 positive population, while the secondary endpoints included progression-free survival and overall survival in the intention to treat population, as well as objective response rate and safety. Among patients with PD-L1 positive tumors, the median progression-free survival was significantly longer in the avelumab and axitinib group versus the sunitinib group, 13.8 months versus 7.2 months, with a hazard ratio of 0.61. In the overall population, progression-free survival was also significantly longer with avelumab and axitinib versus sunitinib, 13.8 versus 8.4 months, with a hazard ratio of 0.69. Furthermore, with regards to responses in the overall population, in the avelumab and axitinib group, the complete response rate was 3.4% versus 1.8% in the sunitinib group. In the avelumab axitinib group, the partial response rate was 48% versus 23.9%. With regards to the overall survival in the overall population, neither arm has demonstrated any benefit yet, with a median overall survival not being reached. In summary, with regards to the avelumab and axitinib combination, and based on the phase 3 Javelin Renal 101 trial, the avelumab and axitinib combination significantly improved progression-free survival compared to sunitinib, both in the PD-L1 positive population as well as the intention to treat population. More patients achieved a confirmed objective response with avelumab and axitinib versus sunitinib, while the follow-up for overall survival is still ongoing. The incidence of grade 3 or more side effects was similar in both groups. More patients discontinued treatment due to adverse events with sunitinib compared to avelumab and axitinib, which was generally well tolerated. I would like at this stage to present two new first-line immunotherapy combinations in the process of receiving regulatory approvals, and then I will follow with a couple of slides of future immunotherapy-related treatments. The first new combination is that of cabozantinib and nivolumab. Cabozantinib is an inhibitor of multiple tyrosine kinases such as VEGFR, AXL and MET, while nivolumab is a well-established anti-PD-1 antibody. They were given as a combination with cabozantinib at 40 milligrams once a day and nivolumab 240 milligrams intravenously every 2 weeks, although subsequently this was changed and nivolumab can also be given as 480 milligrams once a month. The pivotal study is the Checkmate 9ER, and on the 4th of March, the European Medicines Agency approved the combination for the first-line treatment of metastatic renal cell carcinoma. Checkmate 9ER is a phase 3 randomized open-label study of nivolumab in combination with cabozantinib versus the standard of care, which was again sunitinib, in patients with previously untreated metastatic renal cell carcinoma. Patients had to have histologically confirmed renal cell carcinoma with a clear cell component, although interestingly, patients with sarcomatoid features also were included. As previously mentioned, patients had to be treatment naive, apart from one exception where one prior adjuvant or neoadjuvant therapy, which did not include a VEGFR targeted therapy with recurrence more than 6 months after the last dose of therapy, was included. Endpoints included as primary endpoint progression-free survival as per independent central review, and secondary endpoints were overall survival, objective response rate, and safety and tolerability. The randomization was 1:1. The published data demonstrate that the trial met all 3 efficacy endpoints in favor of the combination of cabozantinib and nivolumab. More specifically, the progression-free survival, which was the primary endpoint, was met with a hazard ratio of 0.51, statistically significant. The overall survival hazard ratio of 0.6, also statistically significant, while the objective response rate was also significantly improved with deep and durable responses. The median follow-up time was 18.1 months, and also there was a favorable safety profile for the combination of cabozantinib and nivolumab, while there was a relatively low rate of treatment discontinuation due to adverse events. The latest immunotherapy-based combination to make an appearance is that of lenvatinib and pembrolizumab. Lenvatinib is an inhibitor of multiple tyrosine kinases, while pembrolizumab is a well-established anti-PD-1 inhibitor. Lenvatinib was given as 20 milligrams once a day and pembrolizumab intravenously 200 milligrams every 3 weeks. The combination is based on the results of the multicenter phase 3 randomized 3-arm CLEAR study, which was published at the New England Journal of Medicine in April 2021, with regulatory approvals not yet in place. In the CLEAR study, patients were randomized into 3 groups. The first one included patients randomized into lenvatinib and pembrolizumab. The second group, lenvatinib and everolimus, and the third group, sunitinib, which was the standard of care. In this busy slide, we can see that with regard to the progression-free survival, there is a clear benefit of the lenvatinib and pembrolizumab group with 23.9 months median progression-free survival versus 14.7 months in the lenvatinib and everolimus group versus 9.2 months in the sunitinib group. Further subgroup analysis favours the lenvatinib-pembrolizumab combination in all groups and especially in the poor risk category. Median overall survival is not yet reached for any of the groups. With regards to the duration of response, the lenvatinib and pembrolizumab group demonstrates median duration of response at 25.8 months versus 16.6 for the lenvatinib everolimus group and 14.6 months for the sunitinib group. All in all, it appears to be a very promising combination and more results are eagerly awaited. This table summarizes additional ongoing phase 3 studies of first-line therapies in advanced or metastatic renal cell carcinoma. Several of these studies involve a VEGFR tyrosine kinase inhibitor and immunotherapy, either an immune checkpoint inhibitor or a vaccine. However, the Keynote 679 study is investigating the combination of an immune checkpoint inhibitor and an IDO1 inhibitor. Despite the promising and encouraging results with checkpoint inhibitor-based therapies, basic and translational research is by no means focused only on those. Future directions include work on vaccine therapies, oncolytic viruses, CAR T therapies, either alone or in combination with radiotherapy or tyrosine kinase inhibitors, and histone deacetylase inhibitors or HDAC inhibitors to improve antigen presentation and T-cell priming. In conclusion, renal cell carcinoma is an immunogenic tumor with high numbers of immune effector cells. The emergence of checkpoint inhibitors, either alone or in combination, has resulted in exciting results regarding patient outcomes. Immune-related mechanisms are also responsible for the emergence of resistance with immunotherapy agents, therefore necessitating continuing efforts for new potent agents. The quest for valid biomarkers is vital for the development of new agents, treatment selection, improved survival outcomes, and cost-effective use of drugs. Thank you very much for your attention. Happy to take any questions.